My name is Nathan Radcliffe. I'm a cataract and glaucoma surgeon in New York City. We have a lot of different options for treating MIGS, and of course, glaucoma comes in a range of severities and also in a range of disease velocities based on how controlled the pressure is. I think one of the misconceptions with MIGS is that you might want to use a lighter treatment for very mild disease and maybe a more aggressive or larger stent for more moderate disease. That's not the case at all. And in fact, we know from our clinical data, particularly from the Hydrus 2 and 3-year data that has been published, that the likelihood of needing a big incisional glaucoma surgery isn't based on how mild or moderate it is at baseline. It's unpredictable. If I have a mild glaucoma patient, I don't know if they're going to become moderate, severe, and need surgery within even a few years. So I want to take my one opportunity at the time of cataract surgery, make the most of it, and use the stent that has the most robust and most documented efficacy and durability that I have. And Hydrus is a stent that we know is large, but still small and safe in terms of the eye, and the data that supports it is large and robust.
This is Nathan Radcliffe, and I'm demonstrating my surgical technique for the Hydrus. I've completed a cataract surgery, including the creation of the Hydrus incision, which for me is a 1 millimeter incision that is parallel to my main wound, and to the right of the main wound, this is a right eye, so it's inferior to the main wound. And I'm getting set up here. I've got my gonioscopic visualization all set up. I'm moving a little viscoelastic around on the cornea, entering through the Hydrus incision. And the Hydrus incision really gives you access, so you don't have to come in and approach the canal at an awkward angle. And so the first thing I'm going to do is use my Hydrus inserter to make a small incision or goniotomy in the trabecular meshwork. And this is just to allow me access to the canal. And here I am making that small incision. And now I can actually get the inserter into the canal of Schlem through the trabecular meshwork. And notice that I'm tilting up about 15 degrees. The Hydrus itself is going to basically use the scleral shelf as a guide to come into the canal. And you see it goes in very smoothly. And here we are, we have a nice placement. I think this is excellent as it is. You'll see I'm going to make a few manipulations, but for right now, I'm just getting you a sort of an oblique view with a gonioscopic lens. And you can see we're in the canal. You can see all the windows there through the canal Schlem. I'm moved the inserter around, so I found I can, in some cases, can use the Hydrus inserter just to push my implant in a little bit more. This is really fine placement, but as you can see, I nudged it in just the slightest amount more to get things tucked away there to a place where I'm really happy with the position of the Hydrus. And if this is uncomfortable, sometimes I'll ask for a Sinskey hook or a Kuglin hook. The Kuglin, I think, has the best purchase, but the Sinskey can work very nicely as well.